Another person with a close association with ISIS, and you see that we've chosen friends today, is Robyn Tamblyn. And Robyn Tamblyn has done a great deal in the field of health service research, and particularly in the field of drug use. And looking at aspects of drug use, not just looking at rare adverse effects and getting hazard ratios and odds ratios. That's important. But the ways in which drugs are used are actually more important because they affect a large number of people. And the avoidable but common adverse effects that are due to inappropriate prescribing, suboptimal use, really create a burden of disease which certainly outweighs the occasional rare event that we spend so much time looking at. And Robyn really has worked in that field for a long time, and I've known her work for, 20 years probably. Robyn, less than that, less than 20 years. But it's felt a long time. Robyn is professor in the Department of Medicine and Department of Epidemiology and Biostatistics at McGill University. She's also known to you as the director of CIHR's Institute for Health Services Research, Health Services and Policy Research. That's a role she's taken on fairly recently, and I think her arrival in that position following Colleen Flood has meant that really two really effective people who really understand the area and also understand the needs of policymakers in served. So Robyn is, I think, a stellar appointment. The only downside to that appointment was that up until then, Robyn was a member of, was on our board of directors, and unfortunately, because of obvious potential conflicts of interest, had to step down from that position. So that was a loss to the board and a loss to ISIS. But it's great to have her back here today, and I think it's particularly appropriate with her background and also her current position to ask her to talk about the future of health services research in Canada. Robyn, thank you very much indeed.
Well, thank you so much for inviting me today. It's just a pleasure to be able to come and speak to you. It's a bit of a formidable task. What's the future for health services research? So consider yourselves from this point forward a large focus group who's going to be providing advice. It's also a privilege to speak about ISIS, which I think is one of the most, one of the greatest Canadian success stories. In a little over 20 years, in fact, you've managed to do something that has taken other countries, other regions 100 years to do. So congratulations from the get-go for that incredible achievement. I am a firm believer, I guess this is, I do it this way, right? Okay. That if you need to figure out where you're going, you need to go backward and look at where you've come from. And that will give you some sense of direction. And so I won't take you back 500 years, but I'll take you back 400 years to the first Canadian hospital, which surprised me was in Quebec City. And in those days, you know, there was no government involvement. It was really the religious orders that provided both health and educational services. And in fact, these nice ladies would take care of you. And at that point in time, you know, in fact, we were dealing with infectious disease as our predominant thing. And so we built hospitals to put people in and to sort of control these infections. And so gradually, due to great public health, kudos to them, and vaccines, in fact, infectious diseases were on the wane in North America. And so we had to do something with those hospitals. So we said, okay, well, let's redesign what we're doing there. And now we've got sort of higher tech care. And so what we need to do is reorganize and redesign the services so that we can actually, you know, use those hospitals for providing that kind of a service. And we came up with ideas of intensive care units and coronary care units. And what's really interesting about that, and this was a randomized trial of stroke units, is, and it just is amazing to me that, in fact, a stroke unit, a reorganization of care to provide better monitoring, not better interventions, same interventions, but better monitoring, trained staff, and so on. I mean, you can see it's an absolute difference of 10% in terms of mortality in relationship to those stroke units. Like, no drug really does that much. It's really kind of amazing what health services organization can really do. Another great example of that, looking outside momentarily, the walls of the hospital where we've spent most of our time, is really with the discovery due to essentially health services research, population health research at the golden hour, where in fact mortality related to trauma, in fact, was influenced by how quickly you got to definitive treatment, is that we reorganized pre-hospital care to train paramedics who would actually provide more definitive treatment on the road before you even got there. And in fact, that resulted in this, which was really kind of interesting. Look at that, just that, providing that organizing pre-hospital care resulted in this kind of a difference in mortality, which is really quite startling. So it says, again, that when we design healthcare services well, in fact, you can have quite an impact on the population. And if we look at the present, and I was just reminded by someone from Wales, he said, if you really want to sell something, tell everybody how good they are, and then how they're going to be in first place, or they're going to be in second place to first place. And so I'm going to commit the first dare, which is I'm not doing that right at the present time. So if we look at the present, we have this situation, aging population, we knew all that already. We have a change from infectious disease to a rise in chronic disease. We have an increasing proportion of Canadians with multiple chronic conditions. And we have this. We're spending now on our hospital-centric system, we're spending a lot of money. We're close to the top. The United States is at the top, of course, but we are close to the top. We're about fourth from the top in terms of our expenditure. And in fact, we're not doing that much better than other countries who are spending half of that in terms of something kind of as crude as mortality. And if you look at across the provinces, is you can see the terrible state of affairs with respect to the territories, where we're spending an awful lot and people are not living very long. And we're spending, equivalent across provinces, the other provinces. If we look at things, not mortality now, but just look at scorecards, and this is just one of many scorecards, on getting value for money. In fact, in terms of equity, in terms of access, in terms of quality, in terms of safety, we're not doing very well. And I would argue that it's because we really have not got our act together to fix and redesign again the services that we need to redesign to deal with now the new challenge, right? So we haven't got there yet. So what do I think needs to happen then in the future, and where does health services research fit into that? Well, there's no shortage of opinions here. I mean, there's a lot of people writing a lot of books on what we should do, and we're having conferences on what we should do. And we're doing sort of tabletop drawing board plans on what we should do. And so now we have to get down to doing it. And we've seen some people take some very radical steps. So here's in one of those, terrible areas like our territories, as they just turned everything upside down. They said, okay, everybody's a co-owner of the healthcare system. We're going to redesign it, and we're going to give you a behavioral guide. And that's your entrance point, not the emergency department. It's a behavioral guide, because 364 days of the year, you're going to have to manage your own conditions, and that's what we need to focus on. Well, a very clever guy here, Harvey Skinner, has decided he's going to invest in that, and he's going to start training health coaches who will actually be sort of the support system. I mean, isn't that an incredible thing to do at this point? Now, mind you, there's no evaluation of this, so we're not going to learn anything unless someone gets going, gets some sort of grant and actually evaluates it, which would be a good thing to do, because if we're going to do something as radical as this, we better evaluate it. But on the far other side of our country, actually, we do have, I'd say, a very visionary ex-scientific director from CIHR, Cy Frank, who actually said, I'm fed up with this. I want to redesign the system. So he got busy. It was for bone and joint problems. And so he said, I think we can do better here. And so he actually, he mentioned to me, is his wall is paper with all this stuff, that they spent a year and a half trying to actually re-engineer every piece along the way and create an integrated care pathway for hip and knee replacement. And in fact, this is what it looked like. He ran a randomized trial and ended up by having really dramatic effects on wait times in order to get an appointment with the surgeon, from the surgeon to the surgery, the length of stay, and time to get the proportion mobile the first day, and in quality of life at 3 and 12 months. Isn't that remarkable that you can do that within a system with so many constraints like we have within the Canadian healthcare system? So I'm feeling as if there is tremendous hope here. And in fact, they're engaging, Alberta that is, in a holus bolus experiment called, I can't remember what they call them, strategic clinical networks. I keep on making up a new word for the S, but anyway, like SPORE, no, strategic clinical networks, sorry. where they're actually putting together the three players: clinical lead and visionary, management lead and visionary and senior, and research lead. And they're putting them together and saying, we're going to make it better, and we're going to continuously make this better. And they're launching 16 of these things. It's paid for through the Ministry of Health. It's really kind of awesome, actually. So what about the rest of Canada? I mean, there are experiments occurring all the time. There's a natural experiment probably every day. And we get into this, and we pilot something, and we show that it works, and then we can't scale anything up. So this is, you know, we've been given this country of pilot projects kind of label. And so from CIHR's perspective, I mean, this is my predecessor basically launching a program which I think is really fascinating, which is to say we want to have three things if we're going to do reform in community-based primary health care, which includes public health, by the way. One is that we need innovation teams, and they really need to actually look at new models of care for how do we do this better chronic disease. It can be things that are cooked up together with the ministries, with the regional health authorities, and so on. But you need to have an end user in there, you need to have a policymaker, and you need to go cross-jurisdictional. So it's really trying to seed the spread. Number two, we're going to fund clinician scientists. And number three, a network so that this can all be shared together and we can do a much more cross-jurisdictional work, like with our success story with the Drug Safety and Effectiveness Network. So that's coming. If we look at another area which I think will be synergistic with this need to actually reform how we deliver care for chronic illness in terms of clinical program redesign, one thing that might help is these transformative new e-technologies, really in three areas: patient empowerment tools, advanced decision support, and population health surveillance. So quick through that, patient empowerment's really fascinating. In fact, there's been so many gains made by actually giving people the power to manage their own conditions. And in fact, here's an example, which is the Kaiser Permanente My Health Portal. In fact, this is a new way that researchers have figured out how to collect information and data for their research. But interestingly enough, through a new health portal like that, changing from, you know, come and see me visits to e-visits, not only do you start reducing the equity gap, because you're letting people access at a time that's convenient for them, but you're actually reducing the number of visits and reducing costs. Also, if you look at telehealth care for asthma, for example, systematically you're getting gains there in terms of actually improved disease control and reduced use of the emergency department. So I think that there's room here. Personalized decision support, we just talked about Doug Manuel's risk calculator, and in fact, these have become very favorite things. We take these complicated survival model, logistic regression models, and we stick them into the back of this so that they become usable knowledge. So you get really personalized decision support. And I think this is something that ICES generates these things probably every day in a report. And in fact, this can be turned around and put into your electronic health record platform as decision support, both at a population level and at an individual level. And that, for example, in this particular study that looked at personalized medication safety alerts, provided alerts through a very complicated survival model to say this person's at risk, and here's the modifiable part is the red chunk that you can actually fix. When it comes to population health, I think there's some other very interesting things. So here's an example of a Canadian researcher. He's from Montreal, but he left to go to the United States, unfortunately, doing real-time population monitoring using essentially everything that's out there on the internet. So this is called HealthMap. HealthMap was actually used to identify the emergence of H1N1. It was identified 3 weeks before the CDC identified it. And in fact, that was because they're actually monitoring news reports, everything that's going on the web. It's really the most remarkable thing, which is this real-time population surveillance. The third area I think will be near and dear to your heart is the era of big data. You're already part of big data, but big data means is something that's coming out of industry, but it's saying you can mine things, you can actually learn things if you actually put all this data together, particularly in a longitudinal way. CIHR will be supporting this kind of thing through what we call the support unit, or a data platform within the support unit that will allow this kind of thing to happen. And I'd have to argue that the birth of big data is in Canada. Big data in healthcare is Canada. We see Nora LaRousse here as in her New England study in the 70s. Eugene Veda, who actually was a pre-ISIS scientist who actually mined the data to look at differences in surgical rates between the UK and here. And Walter Spitzer, who, bless his heart, I could not find a picture of him, and this young little lass here called Sammy Suisa, who now heads the Drug Safety and Effectiveness Network, with his incredible work using the Saskatchewan databases on phenadrol, which was an asthma medication that was killing people in New Zealand and Australia. And so the Canadian databases were used to actually figure out what was going on. So I think that we can take what our huge hometown advantage and take it to the next level. So there's going to be new ways of doing research. We're going to start adding a lot of the clinical data that's going to be available in digitized form. So here's an example of the research data warehouse at the Harvard Academic Health Network, consisting of 16 hospitals, and people were able to actually assemble their data sets online using essentially a metadata kind of a system. So this is sort of a web-based interface to assemble your cohorts online. Here's another example, which is the Veterans Administration, and here they're generating real-time disease cohorts or disease registries from their 360 get that, different electronic medical record systems within the same organization. So you don't need to be, I'm going to use the same system. What you need is a way of harmonizing it so that you can actually generate data that means the same. So I think this is quite exciting and probably a way forward in the future. And here's a third model, which is very interesting. Reichenstrau's been at this for about 40 years. It now uses its integrated regional system of both hospital and community care to start generating lists of people. And they can be lists of people for studies, lists of people for preventive care, lists of people for who actually need to be called up for a follow-up. So these are exciting times, I think, in terms of the use of new data. And the investments that probably will be made in research are going to be predominantly in the clinical care redesign. We really need to get that done because we're going to be deep in debt if we don't get it done. So a fair bit of work in that area to actually generate the capacity to look at different, more innovative models of care. I think we've vastly underutilized what an international network could do for us, which is in comparing ourselves to other nations. So big differences in private-public sector funding mixes and in ways of handling inequities in terms of access and outcomes reside essentially in this international network which we could mine. And finally, the third area is that there's going to be a lot of pressure with new technologies, new biomarkers, new drugs pushing up at the bottom of the system, and we need to actually invest in what we need to de-invest in if we're going to move forward. So I would like to say that I'm looking forward to ICE's leadership in the next decade. I think you've got all the right things on the ground to do it, and happy anniversary.